So welcome everybody. As people start to trickle in, I just wanted to take the opportunity to thank the audience for being here today, and especially Dr. Michelle Jacobson. So on behalf of Dr. Kelly Metcalf and myself, we're really delighted to have Dr. Jacobson here. Some of you may know her already, and she is the director of the aftercare clinic at Women's College Hospital, and she does a lot of work with women who have undergone premenopausal or early surgical menopause, as well as women who perhaps are facing some menopausal maintenance issues following a diagnosis of cancer. And so we're very happy to have you here, Dr. Jacobson, to be talking about sexual function considerations, specifically in women with breast cancer. And like always, please feel free to put your questions in the question and answer box. And at the end, we'll do our best to try to navigate some of the questions that come up. And again, just a little reminder to try not to ask very personal questions and try to keep them a little bit broad so that the entire audience can benefit from the answers. So thank you again, Dr. Jacobson, and we'll leave it to you.
Thanks, Joanne, for the introduction, and thanks everybody for taking the time out of your schedule to attend today. I am happy to answer any broad sort of questions afterwards, like Joanne alluded to. Most of what we're going to talk about today is very specific to women with breast cancer, but some of it will also be applicable just to women who are struggling with menopause in general. All right. So our objectives today are to get a sense of the diagnosis and evaluation of genitourinary syndrome of menopause, which is what the term that we use to refer to what happens to the lower genital tract in menopause, and sexual dysfunction. Discuss the management of sexual dysfunction in patients who have had breast cancer and may be taking aromatase inhibitors or tamoxifen therapy, as well as ovarian suppression. And try and help recognize when it's important to get a subspecialty referral in case the physician that you're seeing or person that you're speaking to isn't able to help you enough. So what is GSM? GSM is a collection of symptoms and signs that's associated with a decrease in estrogen and testosterone to the vulva, vagina, urethra, and bladder. So we think of the vulva, vagina, urethra, and bladder as being the lower urogenital tract. And we know that there are estrogen and testosterone receptors along that tract. And there is an atrophy. So those receptors, when they're not being stimulated by estrogen and testosterone, there's a change in the way the actual tissue looks. So in the vagina, this might present as vulvovaginal atrophy, which could be dryness, irritation, burning, or discharge. The sexual piece could be pain with sex, which is called dyspareunia, or trouble with arousal and lubrication. There may even be a change with the way women are able to have an orgasm. Lower urinary tract dysfunction could be overactive bladder, where people are waking up to pee several times at night. That's called nocturia. Recurrent urinary tract infections, or the feeling of a urinary tract infection, and pain with peeing, which is called dysuria. Vulvovaginal atrophy is a common condition. So about 50% of postmenopausal women will develop it. And unlike hot flashes and night sweats, VVA is something that will get worse over time. So the usual symptoms that people associate with menopause tend to get better the further away from their menopause they get, but symptoms of vaginal atrophy tend to get worse over time. And we think of this as a chronic condition. As time progresses, 50 to 80% of women will develop it. It tends to be underdiagnosed because oftentimes women don't want to talk about it or embarrassed to bring it up with their physicians, or the physicians are embarrassed or they don't really know what to do with it. So they brush the symptoms under the carpet and don't really want to talk about treatment, or they say, live with it. Or the worst thing I've heard, which is dyspareunia is better than no pareunia, which one male physician said in response to a patient I had with pain with sex, which means having pain with sex is better than having no sex at all. And I would argue that that's probably not true. Some women will just think that this is part of aging, so they may not know that this is a condition that can actually be treated. And some physicians may not know how to treat it, or may be uncomfortable prescribing therapies for it. So this is something that I want to make you aware of so that you feel empowered to bring it up with your doctor or nurse practitioner, whoever takes care of you, and then bring it up with a subspecialist if needed, if that physician's not able to help you. So we think of a cascade of events in genitourinary syndrome of menopause leading to a negative impact on quality of life. And what's very important about GSM is that many women will have signs of GSM if you were to examine them. So it's quite normal in menopause to see vaginas that are dry and pale and lack of lubrication or small in caliber. But unless that has an impact on the patient's quality of life, it doesn't really matter. So if somebody's getting recurrent urinary tract infections and that bothers them, that's important. If someone has pain with sex, that's important. But they have to have symptoms in order for this to actually be important. So we know in menopause that there's a low sex steroid availability, the estrogen and testosterone levels go down. That leads to an atrophy or dryness of the lining of the vagina, the epithelial cells, less fluid being secreted, reduced levels of the normal bacteria that live in the vagina, and a subsequent increase in the vaginal pH. So the vagina is meant to be an acidic place. The bacteria that live in the vagina are meant to be acid producing bacteria. And when you get a change in the normal bacterial levels, you get a resultant dryness and elevation in the pH that can actually be tested for even with simple pH paper. The genitourinary syndrome of menopause is what happens when you start to get symptoms from these changes. So dryness, burning, itching, pain with sex, bleeding with sexual activity, pain and burning with urination. And that then leads to a negative impact on the quality of life, where you might be in physical discomfort all the time, maybe only during sex, maybe dissatisfied with sexual intercourse, or having inconveniences where you are afraid to even leave the house because you think you're going to have to go to the washroom so frequently, or avoiding sex because it's painful, and the resultant feelings of sadness or inadequacy that come from that. When it comes to managing the GSM, we always want to make sure that your doctor asks about it. And if they don't ask, please feel free to offer this information up because it's important. We need to recognize, we need to be empathic, and we need to educate. We need to give you advice about the things that you're being sold in the drugstores and pharmacies that may actually be damaging to your vaginal epithelium. So we don't want to be using the products that are designed for cleaning the vagina, or people wearing pads because they've got irritating discharge constantly. These are all things that should be avoided because they can actually worsen vulvovaginal irritation. No home remedies, no sticking garlic up your vagina because you read that it was going to help. All of these things can actually cause worsening irritation and problems. And we want to make lifestyle changes. So smoking cessation, toileting, make sure we're wiping from front to back, something called bladder drill, where even if you don't feel like you need to go to the washroom, you go once an hour, sit down, empty your bladder, change position where you stand up and sit down again, and empty it completely so you don't feel like you have to go again right away. We want to minimize fluid intake at night and remove dietary irritants or minimize them, like caffeine. And when we examine you, we're looking to confirm atrophy. And atrophy is what we see when we examine you, where it looks dry and pale and small in caliber. But we also want to make sure that when we examine you, we're looking to make sure you don't have an associated condition. So there are skin conditions like lichen sclerosis and lichen planus. There are other vulvar conditions. There are precancerous cells on the vulva that have nothing to do with being a BRCA carrier. Some women have prolapse, and that leads to pain and dryness and pressure. Some women have had surgery and have scarring in the vagina. And women who've had bone marrow transplants can actually have a condition called graft versus host disease of the vulva and vagina. And it's important that when we look, we rule out all of these associated conditions so that we can make the diagnosis that all that's going on is genitourinary syndrome of menopause. The most common symptoms of GSM are vaginal dryness and dyspareunia. And so it's important that your physician ask you about this, or that you offer this information up so that we're able to diagnose you properly and do the right thing when it comes to examining you and prescribing for you so that your symptoms are improved upon. When we examine you, we want to take a complete history and do a physical examination where we look at the vagina for the signs that we just talked about. We want to look at the skin of the vulva. We want to look for scarring above the clitoris, the shape and size of the labia minora to see if there's fissuring or attachment or shrinkage. And we want to ask you about your symptoms, because the only way this diagnosis gets made is if you are bothered by your symptoms as well. Simply having these changes on examination without any associated symptoms is not important. It doesn't need to be treated unless it bothers you. How do we treat it? First line therapy are lubricants and moisturizers, and there are lots of different lubricants and moisturizers available out there, and I'll go over some of the ones that I think are particularly good. We have the option of using vaginal estrogen therapy, and this is true for women who are high risk for breast cancer and for women who have had breast cancer. So there's a little bit of controversy out there that we'll get into later about whether it's safe for women who have had breast cancer to take vaginal estrogen therapy. But the overall conclusion and recommendations by large bodies is that it is safe to use vaginal estrogen treatment for the management of genitourinary syndrome of menopause in women who have had breast cancer, including in women who are taking aromatase inhibitors. Newly on the market, we have vaginal DHEA inserts, which actually have no black box warning against the use in women who are taking aromatase inhibitors or who've had breast cancer. We also have an oral treatment that can be used for women who are not already taking an aromatase inhibitor or tamoxifen therapy that's meant for the treatment of vaginal dryness. And this is particularly helpful for women who can't access their vaginas. Perhaps they've got bad arthritis, perhaps they're very obese, perhaps they're handicapped and they're not able to get in the position to insert something into the vagina. For those women, using oral therapy may actually be very helpful. We know we can use systemic menopausal hormone therapy, so the same type that you would take by mouth or through the skin to manage hot flashes and night sweats, and you're going to get an additional benefit in the vagina, but that's going to be contraindicated in women who have had breast cancer. And there's also the opportunity to use vaginal laser therapy, which I'll talk to you about later about the risks and the benefits of using it. When it comes to moisturizers and lubricants, there's not actually a lot of evidence out there that says that these work particularly well, but anecdotally they do, and there's very little harm to using them. So moisturizers are going to be something that you use 2 to 3 times a week minimum, and it has nothing to do with how often you're having intercourse, if at all. They're used for comfort and for moisture. They are the first line treatment for dryness in the vagina. You want to use something bland and not irritating. So rather than purchasing vaginal moisturizers from the pharmacy, you want to be using something bland and moisturizing like coconut oil, shea butter, even Vaseline. These are going to be non-irritating and very, very moist. When it comes to lubricants, and these are particularly helpful for sexual intercourse and reducing the friction, you want to be using something that is water-based or silicone-based or oil-based. Water-based is particularly important if you're using a condom, but if you're not using condoms and you're looking just for some sort of lubricant for sexual play, something silicone-based or oil-based is going to be less sticky over time. Again, coconut oil is a good option, as are the silicone-based lubricants. There are some out there called Pure. There's one called Uberlube. These can be purchased anywhere, either online or in the pharmacy, and these tend to be very, very slippery. When it comes to using vaginal estrogen therapies, there are several options on the market, and these are all by prescription. There are creams, there are tablets, and there's a vaginal estrogen ring. All of these are available by prescription anywhere in Canada, but whether they're covered by provincial drug plans or by private drug plans really depends on what your drug plan covers. These are given in different frequencies. So the creams and the tablet tend to be given daily for 2 weeks and then twice a week on an ongoing basis. And again, these are chronic therapies. So you have to continue using them forever if you want them to continue working. If it's not bothering you or you're not trying to be sexually active, it may not be necessary to continue using these, but as long as you want them to work, you have to continue using them. And these are not the kinds of things that you use just when you want to be sexually active. These have to be used on a maintenance basis to help with ongoing symptom control. The estrogen ring gets inserted into the vagina and changed once every 3 months. So it releases a small amount of vaginal estrogen daily, but gets changed once every 3 months. And this is particularly good for women who maybe can't remember to use it or who visit their physician once every 3 months and want help with the changing. Many women are able to do this by themselves and are encouraged to change it by themselves. And the tablet is used similarly to the to the creams. There are a couple new products that have become available in 2022 in Canada that are sort of newer options for the treatment of GSM. So one of them is called Prasterone, and this is intravaginal DHEA. So it's a weak testosterone that is impregnated into an ovule that contains palm oil and coconut oil. And as that ovule melts every day, it releases both the active ingredient, which is the DHEA, and the moisturizing component of the oil. So it sort of is a dual hitter. It's going to give you your moisturizer and your active component. The DHEA doesn't get absorbed into the system because there's no mechanism for absorbing DHEA into the bloodstream. It just gets used in the vaginal epithelial cells where it gets metabolized into testosterone and estrogen within the cell. So it's particularly helpful for women who have had breast cancer, including women who are taking aromatase inhibitors or tamoxifen therapy, because there's really no means to absorb it into the system, and there is no black box warning on the product. So when you open a vaginal estrogen product that's been prescribed for you, it's going to say in big letters in a big black box, don't use this if you've had breast cancer. So I'm comfortable prescribing it. Your oncologist might be comfortable prescribing it, but you might be very worried, because we're all worried about the risk of breast cancer recurrence. And when you see that written in black and white on your prescription, that's going to be maybe affecting your willingness to try it. And if you don't try it and you don't use it, it's certainly not going to work. We don't have to worry about that with the prasterone, because it is technically approved for use in women who have had breast cancer and are on treatment for breast cancer. Ospemifene, on the other hand, is the oral tablet that I was talking about, and this is the only oral product that's indicated for treatment of vaginal dryness. So this is a tablet that you take every single day. You wouldn't want to use this in somebody maybe who's had a blood clot in the past, but that would really be the biggest contraindication. You also don't use this in women who are already taking tamoxifen or an aromatase inhibitor. So this ospemifene is the same class of medications as tamoxifen, so you wouldn't use both of them at the same time. But for women who have completed their treatment for breast cancer and are no longer taking tamoxifen or aromatase inhibitors, this medication would be a great option because they take it orally, it treats the dryness in the vagina, but also is good for your bones and potentially protective against breast cancer in the same way that tamoxifen is. The one thing to sort of consider about this is that it, again, is not going to be covered by most drug plans and should not be taken in women who are already taking any kind of hormone replacement therapy, including tamoxifen and aromatase inhibitors. And we sort of talked a little bit about this already, but this is how they work. The intravaginal prasterone gets metabolized into estrogen and testosterone within the cell of the vaginal epithelium. The ospemifene acts as an estrogen in the vagina, but it acts as an estrogen blocker in the breast. It also acts as a bit of an estrogen blocker in the brain. And for that reason, women who already have hot flashes might notice a worsening in their hot flashes. Let's move on and talk about libido. Now, libido is a big component of discussion around sexual functioning. We don't have many products that are approved for the use of hypoactive sexual desire disorder in women in Canada. We do not have a testosterone product that is approved for use, but we do have guidance from the International Menopause Society on how to prescribe testosterone therapy for women. And what we do is take a male product called androgel, which is 1% testosterone, and give it in 1/8 to 1/10 the dose to try and improve libido. Testosterone is not going to make you more attracted to your partner. It's not going to make you like your partner better. It's not going to take away the stresses of life that impact libido. Testosterone is helpful simply for replacing our endogenous testosterone levels that may have been lowered by surgical removal of the ovaries and menopause. If it doesn't work for you after the first couple of months, it's not going to start working. And if you get side effects on your mood, especially like more irritability, then it may not be a great option to continue on. The most common side effects are acne and hair growth. And because it's an off-label treatment, we're going to monitor testosterone levels to make sure that you're not using more than is prescribed for you. This is an off-label product in general, and that includes for women who have had breast cancer. It would be a complex discussion to decide if this was something that was worth trying or not. But keep in mind that many years ago, testosterone therapy actually used to be used for the treatment of breast cancer. So this is something that technically should be safe to use when you've had breast cancer before. And in fact, with the use of an aromatase inhibitor, you know that there would be no mechanism for changing that testosterone into estrogen and may be a good option. The other option for improving libido is a medication called flibanserin. Flibanserin is an antidepressant therapy. However, it is not prescribed as an antidepressant and it is not useful for mood. It is used only for the treatment of libido, and that's what's approved by Health Canada for. It's approved for use in premenopausal and postmenopausal women. The downside of this medication is you have to take it every single day. And a lot of women don't want to take an antidepressant every day to try and improve their libido. That being said, it is on label, it is covered by drug plans, and it is relatively safe. You have to be cautious if you're already on an antidepressant, because using 2 antidepressants could cause something called serotonin syndrome, which means that the serotonin levels get too high because you're using 2 things that sort of block their reuptake. The other thing that's incredibly important when it comes to libido is managing behavior. So these are discussions I have a lot with my patients, but there are a lot of different ways that you can mitigate libido problems that don't all have to do with taking medications. So one of those things is planning sex. And it sounds very funny because why would we want to take the spontaneity out of it and talk about scheduling sex? The problem is when you have a libido issue, you're not going to spontaneously want to start having sex. And for that reason, if you want to reintroduce intercourse and sexual play back into your usual repertoire, you might have to consider scheduling sex because it's going to be really the only opportunity you have for having it on a regular basis. Now, I'll caution you that if you have pain with sex and sex is not pleasurable for you, scheduling sex and doing it more frequently is not going to be helpful. You want to make sure that if you're scheduling sex, you're doing it to improve the frequency of your libido, but not necessarily because it's going to make sex less painful. And if you don't enjoy it or don't like it, then I would suggest not doing it. You need to figure out the cause of the pain and treat the pain before you start having sex more frequently. Let's move on and talk a little bit about some special considerations for women who have had breast cancer. Okay, so I like this because this is a woman with breast cancer who's doing her usual daily, going to the grocery store, taking care of her kid, all that stuff, in contrast to a man with the flu who is in bed. So we know that breast cancer is common both for women who have hereditary breast and ovarian cancer syndromes and for women who don't. So we know that this is particularly applicable to our younger patients who develop breast cancer. Maybe that's how they found out about their BRCA mutation, for example. About 36% of cancers diagnosed in women 30 to 49 will be breast cancer, and there are significant impacts of breast cancer treatments on sexual functioning and libido. More and more women are being treated with chemotherapy, especially when they get triple negative breast cancer. That's going to usually put women into menopause while they're on treatment. And for some women, they may not get their periods back later. Some women who have estrogen receptor positive breast cancer are going to be treated with medications to put them into menopause, which can have sexual function implications. And other women who carry breast and ovarian cancer genetic mutations are going to be recommended to have their ovaries removed. And that surgical menopause can have a profound effect on their sexual functioning. On top of the effects of menopause, we're also going to be treating women either with aromatase inhibitors or tamoxifen therapy, and it's become the standard of care for premenopausal women who have breast cancer. There's going to be downstream effects on the sexual functioning from those treatments as well. So tamoxifen puts you at increased risk for blood clots, for endometrial hyperplasia and endometrial cancer, and is often associated with vasomotor symptoms like hot flashes and night sweats. It also has variable effects inside the vagina. So some women will have very heavy discharge with tamoxifen, and other women will feel very, very dry. On the other hand, aromatase inhibitors, which require you to be menopausal to use them, either chemically menopausal, surgically menopausal, or naturally menopausal, are going to have a profound effect on the vagina, where dryness is one of the most common symptoms women complain of, in addition to joint pains like arthralgias in lots of the different joints and vasomotor symptoms. We know that this can impact a woman's body image. Certainly, there can be fertility considerations. The menopause can have significant effects on quality of life, sexual functioning, as well as osteoporosis and cardiovascular disease. The reason we treat women who've had breast cancer premenopausally with tamoxifen or aromatase inhibitors come from these studies called the TEXT and SOFT trials. They looked at outcomes using tamoxifen therapy and exemestane, which is an aromatase inhibitor, with ovarian suppression compared to without ovarian suppression. And they found significant improvements in breast cancer recurrence outcomes in younger women under 40 who were using ovarian suppression in addition to their tamoxifen or aromatase inhibitors. In terms of which one to choose, were tamoxifen or aromatase inhibitors better? Aromatase inhibitors are very slightly better at reducing the risk of breast cancer recurrence, but not necessarily enough to be the only choice for women who have significant side effects. The bottom line that we take away from these two trials is that for young women who have estrogen receptor positive breast cancer, using ovarian suppression can be very helpful for breast cancer recurrence. Obviously, when we use ovarian suppression, we're going to run into the same troubles that we do with menopause in general. So hot flashes are very common, mood problems, joint aches, vaginal dryness, decreased libido, pain with sex, as well as osteoporosis, insomnia, and fatigue. If that doesn't sound great, you're also dealing with breast cancer on top of it. We know that when it comes to removing the fallopian tubes and ovaries, the prevalence of sexual dysfunction after risk-reducing BSO is 74%. So a vast majority of women who are untreated, who have their tubes and ovaries removed preventively, will also have sexual dysfunction. We know that more than half of women affected by cancer are also going to have adverse sexual effects. Despite that fact, there is no specialty better qualified to care for this than OBGYNs. And at the same time, I can tell you a lot of OBGYNs are not comfortable treating women who have been affected by breast cancer because they're worried that they're going to cause a recurrence. And there's so much of this that's nuanced and difficult that it ends up being a really important conversation to have, including the patient, including her gynecologist, ideally a menopause specialist, and potentially the breast medical oncologist. These are the 9 domains of evidence that underline the assertion that ethical and humane care needs to be given to women and girls affected by cancer to preserve sexual function. Most women and girls with cancer have a cancer that affects their sexual organs directly. Cancer and cancer treatment can impair female sexuality. Women and girls with cancer value their sexuality. Loss of sexual function has negative health consequences for women and girls with cancer and their partners. Patients want to preserve their sexuality, but rarely talk about it or ask for help. We need better evidence on how to optimize their sexual outcomes. We need better research to establish the efficacy of treatments for female sexual dysfunction in the context of cancer, and special effort should be made to include women and girls of sexual minority groups. Sexuality is an essential component of physical health. The fact that this had to be published, even though so much of this is common sense, should give you some understanding at how little physicians learn about this and how uncomfortable they are in terms of treating it. So this says, Doc, can you write me that prescription for some Viagra? And the partner behind him is saying, say no. So men feel like if they can take medicine for an erection, that the next obvious step is to be having intercourse. What they may not realize is that their 25-year-old erection, which is being given to them from their Viagra therapy, does not necessarily match with their patients, with their partner's 60-year-old vagina. And again, having painful sex is worse than having no sex at all, because as soon as your brain learns that sex is painful, it will immediately tell you to not allow yourself to have sex voluntarily. Your body doesn't want to experience pain. So in the same way that if I throw a baseball at your face, you're going to flinch and turn away without any ability to control that, your brain is going to tell your pelvic floor muscles to clench down and not allow penile penetration because it knows it's going to be painful. Can we use vaginal estrogen in women who have had breast cancer? This is just an example of the different estrogen preparations out there and the maximum annual delivered dose. So I want you to pay attention here to the fact that in a year, if a woman uses VagiFem daily for 2 weeks and then twice a week, her annual delivered dose of vaginal estrogen to her system will be 1.414 milligrams. If you contrast that, for example, to an estrogen patch or estrogen pills, the difference is 182 milligrams compared to 1. So using estrogen vaginally is not the same as using it systemically to help with hot flashes and night sweats. We absorb very little estrogen vaginally, and theoretically, there should be minimal to no increased risk of breast cancer recurrence from using vaginal treatments. The American College of Obstetrics and Gynecology supports the use of estrogen in the vagina for breast cancer survivors. This was originally written in the early 2000s and has been reinforced and reaffirmed as recently as 2018. Women on aromatase inhibitors who experience urogenital symptoms refractory to non-hormonal approaches, so they're taking aromatase inhibitors and they've used treatments that are non-hormonal and these haven't worked, may benefit from the short-term use of vaginal estrogen. ACOG suggests potentially, if you're taking an aromatase inhibitor, switching to tamoxifen therapy while using the vaginal estrogen, because there's theoretically no risk of using vaginal estrogen with tamoxifen. Tamoxifen blocks estrogen receptors, so it competes for them. It doesn't depend on a complete absence of estrogen levels in the vagina, whereas aromatase inhibitors stop estrogen production from being made, but don't do anything for estrogen receptors at the level of the breast and the cancer tissue. So in theory, it's much safer to use vaginal estrogen if you're taking tamoxifen. And some people would suggest in a particularly aggressive cancer to consider switching back to tamoxifen if vaginal estrogen needs to be used. as opposed to continuing on an aromatase inhibitor and using estrogen vaginally. I personally have never seen that done. Most of our medical oncologists are okay with a patient taking vaginal estrogen on an aromatase inhibitor. There are a couple options for using vaginal estrogen, but the ring, because of its constant 7.5 microgram a day production of estrogen, gives very constant levels after 12 weeks of use. That's in contrast to using something like Vagifem tablets or cream, where you get a bolus of estrogen and then a slow decline as that estrogen gets used up over the course of the 2 times a week that it's being used. So it may be safer to use something with regular estrogen production than the kind of thing that you use a bolus twice a week. And then, of course, we have the options of the progesterone and ospemifene, which I spoke about earlier and will speak about again. This study was published in 2022, and it was a large observational cohort study. So they looked at thousands of women who had breast cancer in Sweden, some of whom were taking tamoxifen, some were taking aromatase inhibitors. They were all treated in the early 2000s, and they gave them either nothing, systemic hormone therapy, or vaginal hormone therapy. And they went back and they looked at their outcomes. What they found is that women who took tamoxifen or aromatase inhibitors and vaginal estrogen had no increased risk of breast cancer death from their vaginal treatment. However, they did find an increased risk of recurrence in the aromatase inhibitor takers who were using vaginal estrogen. This is a flawed type of study because it just looks at women, all comers who have breast cancer. They don't look at specific characteristics. So they can't necessarily say vaginal estrogen caused an increased risk of breast cancer recurrence. But what they can say is that there was an association. And is it because the women who were taking aromatase inhibitors had higher risk disease? We don't know. That kind of information doesn't come out of these studies, but certainly it does give pause to people like myself who are prescribers of vaginal estrogen. And I really do think twice before giving estrogen to women who take aromatase inhibitors. Those same treatments that we talked about before, the progesterone and the ospemifene, may be better option. So the progesterone is going to have included women who had breast cancer in their original studies. Again, this is going to be vaginal DHEA compounded into a moisturizer. It's going to be a daily treatment, so you don't get those infrequent boluses of therapy. And we're not going to see any significant absorption of the DHEA from the vagina, and therefore no real systemic estrogenic activity. This is going to be on label because it does not have a black box warning. Ospemifene, on the other hand, is going to look like tamoxifen. We don't give tamoxifen and aromatase inhibitors together for breast cancer, so we wouldn't give ospemifene with tamoxifen, and we wouldn't give ospemifene with an aromatase inhibitor. This is going to be for women who didn't need to use treatment or who had completed their treatment already and are now looking for control of their vaginal symptoms. Should ospemifene replace tamoxifen? They're similar. Not yet is sort of the simple answer, but there is some evidence that ospemifene works similarly to tamoxifen in the breast, but not quite as effective. So I don't think we're going to be seeing women switching from tamoxifen to ospemifene if they still need the tamoxifen for their breast cancer treatment. This would be a reasonable option for women who have GSM, who have completed their adjuvant therapy and are not currently taking tamoxifen or aromatase inhibitors, and women who have not had a blood clot in their legs or their lungs. And the last thing I'm going to touch on before we take questions is on laser therapy. So you'll see this sold by physicians. Some of them are gynecologists and some of them are going to be just people who do regenerative medicine. There are lots of different laser treatments out there. Some of them are CO2, some of them use an element called erbium. The idea behind these laser treatments is that they cause micro trauma to the vaginal epithelium. And then when your body is repairing those micro traumas, it gives a brand new layer of epithelium. And that's why you need to continue having this as a treatment. This is not going to be covered by drug plans. The cost is usually in the realm of about $2,000 for the original 3 treatments, and then an additional maintenance fee. This is not something that is recommended for everybody. And I would say that there is a little bit of controversial recommendations on whether it's used or not. This is kind of what it looks like. So it's not painful, but it causes micro trauma inside the vagina. There are studies that look at whether this is helpful, and they have found that women who have vaginal dryness or pain have an improvement across the female sexual function domains with this treatment. However, there is also a warning from the FDA that this may or may not be safe enough yet in women for treatment in the vagina, and that they don't recommend it yet. So I think this is still something that is an option for women who want to pay and try it, but is not necessarily backed by the strongest types of evidence. The most consistent predictor of satisfying sexual experiences in women with breast cancers is actually the quality of their relationships. So don't assume that the trauma of breast cancer treatment hasn't affected your relationship, the way you feel about your partner, the way you feel about your body, the way your partner feels about you. Your partner may be worried about hurting you. That may impact his or her interest in initiating sexual care. He or she may not know if you enjoy it. So having really frank conversations is important. And so is engaging in couples or sexual counseling when it comes to, I've made it past the trauma of my breast cancer diagnosis, and I'm ready to start talking about reintroducing sexual function into my life, what that looks like, and how to do it in a way that is safe and not painful. So in summary, when it comes to the treatment of sexual dysfunction, we need to ask, or you need to offer the information if you're not asked. All patients can start vaginal moisturizers really as soon as treatment or menopause starts. That's lubrication with intercourse and moisturizers on a regular basis. If you have continued pain or issues with intercourse, you can introduce vaginal estrogen, or you can introduce one of the newer treatments like oral ospemifene or vaginal progesterone, and consider laser treatment if available and affordable, or if you've tried the other treatments and they haven't worked for you. I really appreciate your time. I wanted to give about 20 minutes for questions.
Thanks so much, Dr. Jacobson. Very informative talk, and I think we all probably learned a little bit in that talk. So we have some questions. Again, I'll remind you, if you do have questions, if you could just type them into the Q&A, and then Dr. Kotsopoulos and I can ask Dr. Jacobson your questions.
So that was really informative and a lot of interesting information that I'm sure most of us are not even aware of. So we're just going to navigate through all the questions here. There's one, I'm going to start at the bottom. Can you talk about vaginal atrophy in the relation to prolapse? And do vaginal creams help with this?
Yeah, so prolapse can cause a sensation of pressure and it can cause urinary symptoms. It usually only causes dryness if the prolapse is so profound that the cervix is actually hanging right out the vagina or is right at the opening of the vagina. Creams absolutely help with this because they're going to help protect the lining from becoming keratinized, which is what happens when moist membranes are exposed to the outside environment that they're not supposed to be. That being said, if you have prolapse, you might want to also treat the prolapse and not just the dryness. And that would be either with pelvic floor physiotherapy, if it's not too bad, or by seeing a urogynecologist and getting treatment with a pessary, which is a little plastic cup that holds the organs that are prolapsing up. And you can use vaginal estrogen with that or with surgery.
And just to reiterate, even the vaginal estrogens, these do require a prescription, correct?
The estrogens and progesterone and ospemifene are all prescription. The moisturizers and lubricants you'd be able to buy anywhere.
And do women have to come see a specialist like yourself, or is this something, and I know it's really dependent on all our, we know there's discrepancies and differences in our primary care physicians, but is this something a primary care physician could prescribe if they were familiar with it?
Could prescribe, absolutely. Will they prescribe it? That's going to be so individualized based on how comfortable they are. You know, I do this kind of talk a lot in the hopes that family doctors and primary care physicians will be comfortable, because honestly, vaginal estrogen is one of the safest things we can prescribe. It can be started at any time. It can be continued forever. And even in the most high-risk women, which would be, let's say, someone taking an aromatase inhibitor, it's probably still safe.
Great.
Okay, thank you.
So there's a question about menopause specialist and who is a menopause specialist. We're lucky enough to have you at Women's College in Toronto, but there are probably many women across the country who may not have access. So can you talk a little bit about what a menopause specialist is and how a woman might access that specialty?
Totally. So there's not a lot of us, unfortunately. There are definitely going to be some family doctors who have an interest in menopause, And one thing you could do is go on the North American Menopause Society's website, and they have a search function where you could find someone who is certified by the North American Menopause Society by doing a search option. So someone who has their NCMP, or their National Certified Menopause Practitioner certification, is going to be well versed in this. You can also contact an organization which is new called the Canadian Menopause Foundation, and they could potentially put you in touch with a menopause specialist who is in your area. There is representation across the country, but obviously not a ton. Some of them are family doctors who have special interest, and some of them are gynecologists who've done extra training.
Great, thank you.
Thank you, Michelle. So this one question is about peeing every hour, and you mentioned that during the earlier part of the talk. And is this for all women experiencing urinary symptoms, or just those as a prophylactic approach to help in the prevention of developing this need?
So, I mean, if you're peeing every hour, you want to be investigated to make sure you don't have a urinary tract infection, because that's pretty low hanging fruit when it comes to treating it. But it is a very common symptom of having genitourinary syndrome of menopause. So if it's bothering you, you would see anyone really to rule out a urinary tract infection, and then you could start the treatment. I wouldn't say that you need to start therapy to prevent overactive bladder, because not everybody who has GSM or doesn't have GSM is going to be affected by an overactive bladder.
Okay, great.
So there's another question about hormone replacement therapy, or HRT. Is it safe for patients with a BRCA1 or BRCA2 mutation after having a prophylactic oophorectomy, and with or without a bilateral prophylactic mastectomy?
Yeah, so hormone therapy systemically, so taking estrogen by mouth or through the skin with progesterone if needed, is safe for women who have had surgery for BRCA and are high risk for breast cancer, whether they've had their breasts removed or not. It is not safe for women who have had a breast cancer diagnosis.
Okay, so that's the distinguishing feature that women should take away from this. If you've had a previous diagnosis of breast cancer, it's not a safe option for you to have HRT the way we think about HRT, taking a pill.
Yeah, not in general. And I mean, it's been a few years, but I'm happy to do that talk about, management of menopause in women with BRCA at some point.
Right. Okay.
Okay. Okay, this one's I'll try to generalize this one about experience. Is it possible to experience vaginal atrophy after being on birth control pill for long-term use of birth control pills? And I guess, is there any predictor of having vaginal atrophy other than being in menopause or premature menopause? Are there some factors that perhaps are associated with a lower risk of developing this?
Yeah, so I'm reading this question, and I think one thing that's important to note is that birth control pills cause your testosterone levels to be very low, because birth control pills increase a hormone called sex hormone binding globulin, and they mop up all of your free testosterone. And just like I talked about using the progesterone in the vagina, there's lots of testosterone receptors in the vagina. So I would suggest that birth control pill long-term can actually cause vaginal atrophy because of the lack of testosterone. So it gives you lots of estrogen, but it blocks all the testosterone in the vagina. And for some women who are young who present with vaginal pain with intercourse or dryness, all we do is take them off the birth control pill, and after several months, their vaginas go back to normal. So in addition to menopause and breast cancer treatments, yes, birth control pills can also cause vaginal dryness.
Okay.
Okay, one other question. Are vaginal creams as safe as Vagifem?
Yeah, so all of the options for vaginal estrogen are considered as safe as each other. One difference is that creams tend to be a little bit better tolerated in women who are extremely dry, because Vagifem, you have to insert a small tablet, and for some women, inserting it is just too painful because they're so dry.
Okay, so we have a lot of questions about whether these talks are being recorded, and also in particular what you just mentioned, Dr. Jacobson, the management of menopausal symptoms and post-surgical menopause. And we have all these talks recorded, and they are available on the website and through YouTube. So yeah, you can go back and see one of Dr. Jacobson's earlier talk also. Okay, so I think we've answered most of the questions in
There's one more that's just come up. And I'll
Here you go.
you can probably see it too, Dr. Jacobson, about delaying oophorectomy and having just your fallopian tubes removed.
After breast cancer diagnosis.
Yeah.
After breast cancer diagnosis. Okay. I mean, it's such a complicated question. So when we talk about removing, let's say, the ovaries, we're talking about doing that twofold. One is for the prevention of ovarian cancer, and we do that at certain times, depending on what kind of a BRCA carrier you are, to reduce your risk of developing ovarian cancer. The other benefit in removing the ovaries is treatment of breast cancer. So we know that women who carry an estrogen receptor breast cancer will do better if their ovaries are removed, if they're premenopausal, or if they take medicine to put them into menopause. And women who have triple negative breast cancer and are BRCA1 carriers may also have a better sort of all-cause mortality if their ovaries are removed. And we don't have a good reason to explain why that might be. So if you're thinking about removing the ovaries, you sort of have to ask yourself, why am I removing the ovaries? Which category do I fall into? So if you're an under 40 breast cancer estrogen receptor positive carrier, there is an additional benefit to ovary removal that has nothing to do with your ovarian cancer risk. If we remove the fallopian tubes, what we're doing is lowering your risk for developing ovarian cancer. That's going to have no impact on your breast cancer treatment or risk. So do I recommend removing the fallopian tubes first? For some women, it's a good option, but it is not yet evidence-based enough to reduce the risk for ovarian cancer. So I would suggest only doing it really in the context of, I'm too scared to make the decision to remove my ovaries, but I want to do something to lower my risk, or I'm part of a study where this is being studied carefully.
Mm-hmm.
And something important that you mentioned, along with preventing ovarian cancer, which is the primary reason we want to remove our ovaries, because we know there's no effective screening and usually is diagnosed at a late stage and with a poor prognosis. Our team and others have shown that when you have an oophorectomy following a diagnosis of breast cancer, it really improves your outcome also. So it is also part of the care of BRCA mutation carriers following a diagnosis of breast cancer.
But I think that the bottom line for all of these types of questions is this area of medicine is really complex, and every piece of advice we give has to be individualized to your specific situation.
Yeah.
We can't
really,
make generalized statements because everyone's situation is so unique in terms of their risk and their fertility planning and what their risks of menopause are, their risks of breast cancer, what their own family history has shown. So it's not enough to just say, I carry this, what should I do? We need to know you.
And the information is evolving. And like we always say, keep in touch with your genetic counselors, keep in touch with your clinicians, and continue to follow up and ask these personalized questions.
Mm-hmm. All right, it looks like we've gotten to the end of our questions. So thank you so much, Dr. Jacobson, for making the time for us today. I know it was hard to fit that into your schedule, so we really appreciate it. This seminar has been recorded, and we will be posting it on our website with all of the other webinars that we've offered in the past. Just also like to remind you of our next seminar, which will be on Friday, April the 14th. Again, we'll go back to our usual time of 12 to 1. And this is going to be a panel discussion about fertility, talking to your partners about your BRCA mutation or another mutation if you carry another mutation in another cancer predisposition gene, and relationship issues. And this will be a panel, and it'll be a chance for you to submit your questions about what you'd like to know about this. So we have 3 experts in this area, including a fertility specialist, our social worker at Women's College who helps women with dealing with some of these struggles, and our genetic counselor in our cancer genetics clinic. She will be there as well. So we will be gathering your questions ahead of time and asking the experts on your behalf. So please join us for that and register for that event if you haven't yet already.
And please continue to send us your feedback. We really do thoroughly review your comments and suggestions to help plan our future seminars. And we're trying to provide some variety. And so we really appreciate all your feedback.